discussion session for health and homelessness. Thanks everyone for coming. Today's topic is veterans and homeless, and we have a lot of great guests today, so it's going to be an exciting session. Again, if you've missed a session or you can't remember how to make it up, that should all be sent to you via email from me, weekly. But you can also check the class website at tinyurl.com/health and homelessness. So look at these introduction slides, look at the PowerPoint from our speaker. Watch the video, these are all recorded, and then take the speaker evaluation, which is just kind of what you do in here anyway. So a couple words about outreach and outreach opportunities. Last night was the foot care, teeth and toes training. Thanks to any of you who were there last night. It was really great. There were students from medicine, nursing, dentistry, public health. And it was the first interdisciplinary training session like this with over 50 students, so it was a great experience. A couple more pictures. Jackie and I did a role play of an oral exam in front of the medicine and nursing students, so they were able to critique my skill, and then Nikki and Rika gave an oral hygiene instruction and oral health information talk. So the next opportunity for volunteering is this coming Monday at Mary's Place. The time hasn't been set yet, but it'll probably be sometime between 10 and noon to start. Another opportunity on Monday morning if you're not able to make the teeth and toes, if you weren't able to do the training session, is the U-District Conversation on Homelessness. And I may have mentioned this in the past, but I don't think I explained what it is. So the U-District Conversation is a grassroots collaboration that involves UW faculty, staff, and students, U-District health and human services providers, faith organizations, business owners, and other community members from the University District. And the next meeting will be on this Monday, Veterans Day, and the topic is community mental health resources for people who are homeless. And they're bringing in three groups and speakers, one from like kind of a neighborhood level to a city level to a county level. And so you can talk about we're going to talk about what mental health services are available at each of those respective levels. Another opportunity is the Common Book series, which is on Dr. Gabor Mate's book, In the Realm of Hungry Ghosts. So the next opportunity for that is next Wednesday, and the talk is Social Determinants of Health, and Dr. Freddie Overstreet from the School of Medicine is hosting that. Is Laura in here? Did you want to say anything about the Center for Hope? Okay. Lori brought to my attention, she works closely with the Reach Center of Hope in Renton, and it's open to any volunteer who would like to, work really closely with women and children and get to see firsthand, what it's like to be in their shoes. There are two different opportunities. One is a day center that you can volunteer with, and then there's an overnight shelter where you can be there overnight with the residents of this place. So if you'd like to sign up, you have to be over 21, you need to pass a background check. But if you want to sign up, contact Lori, and hopefully you can go down to Renton and check that out. So the survey is in the attendance kind of as per usual. Just make sure you sign in so we have you, more than just being here. So without further ado, let's welcome Dr. Simha Reddy to talk about veterans and homelessness from the Seattle H-PACT program at the Veterans Affairs Office.
So, I'm going to hold this. It's a little tricky for me. So first of all, I just want to thank you all for having me here. It's just such a pleasure getting to talk to folks who are really interested in this topic. It's a real passion of mine, and just excited to be here. I also just want to take a moment and just mention how impressed I am by the folks who organize this course, because it's not every course that has math and more on their syllabus. If you haven't checked it out already, I imagine you have on your course website. You've got a great video from him about homelessness here in Seattle generally. But today I'm going to touch on these three topics here. Just a little bit about homelessness and health. I know you've already probably heard a lot about that, but I want to try and illustrate it with a case example. A little bit about, and then some about the VA efforts, and then what my personal experience has been doing outreach as a primary care physician into the community. But I'm going to try and limit my remarks to just about 15, 20 minutes or so, because we're really lucky today. We have veteran Joseph Blaze, who's agreed to share his story with us today. So just starting with the basics, is the impact of homelessness on health. And homelessness affects health in a great number of ways. But probably the most striking is just its effect on even mortality. So I'm going to ask for a little bit of audience participation here, just raising of hands, okay, so nothing dramatic. But so I want us to take a guess at sort of the mean age of death of people who are homeless here in King County. And this is representative of sort of across the nation, multiple studies, both prospective and retrospective. Just to give you a sort of frame of reference, the life expectancy of somebody here in King County is between 75 and 80, depending on your demographic. And something like having type 2 diabetes is kind of poorly controlled when you shave 10 years off of that. How many people think, by show of hands, how many people think the average age of death of somebody who's homeless here is above 75? How about between 70 and 75? 60 and 70? All right, between 50 and 60. All right. How many people think the average age of death for someone who's homeless in King County is less than the age of 50? All right, well, congratulations on being both really cynical and correct. So, you know, there's obviously a little bit of spread here, but homelessness has dramatic impact on health, and it means shaving decades off of people's lives. People are dying of sort of major causes are things like injury, both accidental and intentional. Then more typical things like heart disease, end-stage liver disease, from hepatitis, alcohol, etc. And poisoning and overdose tend to be sort of the biggest contributors to death. But additionally, there are a lot of barriers when you're homeless to accessing traditional medical care and dental care. And I wanted to just illustrate that with a bit of a case example. So this is actually based on a patient of mine who has unfortunately since passed away. But he was a 52-year-old gentleman who was living down in Spokane, who has end-stage liver disease complicated by hepatic encephalopathy or confusion related to liver disease, as well as ascites or buildup of fluid in the abdomen. But he came out from Spokane to be with his girlfriend, and when he got here, he found that she was using meth, and he was in recovery, and so he was pretty worried about this. Now, if you were in his shoes, by show of hands, how many people would stay with the girlfriend and really risk your recovery? Anybody? How about moving out to a shelter? It's your other option. Yeah, pretty reasonable, right? I think if I were seeing him in clinic, I would advise him to try and stay away from those influences that might really affect his recovery. So let's say he goes and stays at City Hall overnight, but in the morning you got to pick up all your things and go, right? He's got his luggage that he brought with him to really set up a whole new life, right? So you've got two options here. One, you take your diuretics, which are going to make you piss all day long, and take your lactulose, which helps reduce confusion, but also if it's working right, gives you diarrhea all day long. So you can take those two medications to control your liver disease, or you say, I'm feeling okay right now, I'm just going to skip it. How many of you would skip your medications on this day? I think it's pretty reasonable. I mean, if you're going strictly by the book, you might say, you've really got to keep the liver disease under control, take your medications, but when you're riding the bus all day long, you don't have access to your bathroom, it's cold outside, there are a lot of barriers to taking your medications correctly. So, starts to build up fluid. And let's say he scrapes his shin and starts developing a little bit of an infection. And here's two options. One, you go to the emergency room, or two, you call the VA and you spend 5 minutes on hold and then get an appointment for 2 weeks out. Which, I gotta say, would be remarkable if you only spent 5 minutes on hold and was able to get an appointment within 2 weeks. That would be just amazing. But your ability to communicate and have minutes on your phone is pretty limited. In this case, it makes sense to go to the emergency room, right? I think in a lot of public conversations about health, we talk about misuse of the ER, right? Well, from the perspective of somebody who is not engaged in regular care or doesn't have access to regular care, it makes a heck of a lot of sense. So I think when you're seeing patients down the line in the future, keeping that in the back of your mind, not make sure you understand where folks are coming from. So let's say he gets treated, gets given an antibiotic, he leaves. Turns out that the antibiotic's not going to work based on the culture results. But nobody can reach him because he's out of minutes on his phone. And infection gets worse. He starts to get more and more confused because he's maybe not taking his medications correctly, but also the infection itself. And eventually somebody finally calls the medics and gets him back up to the hospital because he couldn't get there on his own. You get admitted to Harborview, you get stabilized, you get discharged, but by the time you get discharged, it's like 6 in the evening, and you're back to the same options you started with. Do you go to that girlfriend, or you go back to the shelters and the streets and do this all over again? These are really hard choices, and there's not, I think, an obvious answer here. That staying healthy when you're homeless is an incredibly difficult thing to do. But you guys hear that, are going to hear that a lot from the various sessions you go through, and I want to talk a little bit more specifically about veterans and homelessness and what the role of the VA is. So we have the Department of Veterans Affairs has a very particular interest in homelessness because, unfortunately, our veterans are overrepresented in this population. They make up only something like 8% of the general population, but between 15 and 20% of the homeless population. And then among the chronically homeless, they're even more overrepresented. And a statistic that's particularly striking to me is that 1 in 10 vets who live in poverty will experience homelessness in a given year. That's a tremendous number of people. Now, I don't know how many of you are aware, I know some of you were here for the talk back in the spring, but this is the Secretary of the Department of Veterans Affairs, Eric Shinseki. And at the end of 2009, he made a pledge, along with President Obama, that we were going to end veteran homelessness by beginning 2015. By January 1st, 2015, veteran homelessness will be gone. And that was the pledge they made, and it's incredibly ambitious. How many of you think that's achievable? So we have a year left. Anybody? All right. So, you know, when I first heard this, I sort of, just before I came on board, I thought it was ridiculous. Like, it really doesn't make a lot of sense, right? Like, this is a huge structural problem. How are we going to end veteran homelessness in 5 years just because we said we're going to do it? My opinion on this has changed 180 degrees. I think it is possible. I think it is achievable. I think it's a matter of will and coordination. When you look at the numbers, we have 150,000 veterans here in Puget County, but only about between 1,800 and 2,400 veterans at any given time who are homeless. That's a lot, but you think about it's not insurmountable, right? 2,000 people in a city, in a county, 1 million or so, or more? That's achievable, I think. In fact, over the last 5 years, or 4 years or so, it's dropped by about 20% or so, which is we're not there yet, but we're making progress right now. And there's a few different ways the VA has been approaching this issue. Primarily, we've been focused on sort of housing and employment, right, which makes sense. So there's a program called the HUD BASH, or the Housing and Urban Development, and VA supported housing, essentially providing housing vouchers for people who are homeless. Transitional programs, some people can stay for 6 months to a couple of years as they sort of get back up on their feet, and maybe have case management, that sort of thing. Rental assistance for if you're in your place and in danger of becoming homeless, that sort of thing. Job retraining, education opportunities, a lot of different possibilities out there. And obviously, and partnering with a lot of our community members as well to help make this happen. But last year, something new came online, something called the H-PACT program, or Patient-Aligned Care Team. The VA loves acronyms, so there's yet another acronym. And the idea is that people who are homeless have unique medical needs. in some ways. There are barriers to accessing both traditional primary care, mental health care, specialty care, and we need to make sure we're addressing their needs in a way that makes more sense than sending out a letter and saying make an appointment in 3 months for your half-hour visit with your doc. And so we're at 38 sites across the country. We've been attempting this new sort of approach to primary care in this particularly vulnerable population. And the approach is very dramatically. So from creating, one-stop shops or drop-in centers in high-needs areas to really intensive case management to just co-locating with ERs where people may be coming in for urgent issues. And then kind of what we do, which is more sort of an outreach approach. And it's not entirely clear what the best possible approach is, but we think we're making some progress here. And just want to talk a little bit about what my experience has been. So I graduated from the internal medicine residency program here just in June or July of last year, and started this job in August of last year, so just about 14, 15 months now. And it's been a really interesting and eye-opening year. And let's start by kind of talking about what our program is. We consist of a pretty small team. So just myself, a nurse, and a social worker. And our job is to sort of focus on two groups of veterans. Veterans who are really high needs. So people who are homeless who have really uncontrolled medical issues or mental health issues. And maybe they're using the ER a whole lot, showing up in the hospital again and again. So reaching out to those folks. But then also reaching out to the veterans who aren't connected with the VA, who maybe got burned somewhere along the way, don't trust us, didn't even realize they had access to resources with us. So trying to connect to those two big groups. And the way we do it is kind of different from your traditional primary care model. Instead of, which is more focused around appointments in the clinic, we focus on really being really walk-in friendly. So if somebody's got an urgent issue, they just show up and we try to take care of them. And we do that most of the week. And then 2 to 3 mornings of the week, we are out in the community at a variety of shelters and hygiene centers, transitional houses, trying to come to other people. And the goal is, obviously providing medical care is really important to me when I'm out in the community. But my biggest goal is building a relationship and trying to build the trust that's going to get somebody to be willing to come in and see us in the hospital and get the care that they might need and get the housing resources that they may be eligible for as well. And all those little blue dots on the far left are sites we go to. So kind of as far south as Renton, we've got a transitional house there, several different locations down in the Pioneer Square areas or at the Hygiene Center. I understand y'all go to Union Gospel Mission quite often, so that's a place we visit on occasion. The Downtown Emergency Service Center, and then as far north as Everett, about once a month. It's basically the only homeless shelter up in it's Homeless County, I think. And there's a lot of veterans there who may not even realize that who don't realize that they are eligible for services. So that's always very fruitful. And just to give you a sense of sort of the places that we go. So on the far left, I think this picture of the urban rest stop, we actually don't go to that one in particular, we go to a different hygiene center. The hygiene center is a place where you go to do your laundry, get washed, kind of feel human again in some ways. And we have a place downtown we go every single week. That's the Compass Hygiene Center. The middle picture is, so the Compass Housing Alliance, you may or may not have heard of it, does tremendous work here in the Seattle County area, providing both transitional housing, these hygiene centers, but also, interestingly, banking and mail services, right? When you don't have money, finding some place to open up a bank account so that you can get checks, like Social Security checks to start coming in, for example, is a huge benefit. Having a place where you can have your mail sent to you that's reliable, where you don't have to pay for a post office box, that's an enormous resource. And finally, just a sign, I think when we think about somebody who's homeless, we often think about where you can sleep tonight. But people are homeless 24 hours a day, and oftentimes, find a place to be that's safe, that's warm, where you can talk with other people is incredibly important. So there are day centers scattered through the area. Compass runs one of them down in Belltown. A couple of the sort of more traditional shelters that we tend to go to, places like on the far left, that's sort of more similar to what you might find at the Every Gospel Mission, Union Gospel Mission, where people will stay on maximum floor at night, and then during the day, maybe that's a place where people can just sort of hang out, or the day center. And then on the far right is just a picture pulled from the DSC website. Downtown Emergency Service Center has been doing just amazing work since the 1970s. They probably take care of the most vulnerable people in the city, that people who suffer from real mental health issues and substance abuse issues perhaps, and just really significant medical issues. People can stay in emergency overnight shelters there as well. So there's a couple of the organizations that we partner with. And truthfully, I think maybe the most important thing what we do in terms of outreach is, I talk about sort of building trust and relationships with veterans, but probably more important is building trust and relationships with community providers, right? So if you show up once or twice and then don't ever come back, nobody's going to really trust you and be willing to refer somebody your way. But if you're there every week, every month, and return all your phone calls, that's when people start trusting you a little bit enough to say, to have somebody come back and visit with you, or to give you a call when they've got somebody in front of them. That makes a tremendous difference. The Every Gospel Mission, talk about Union Gospel Mission, Compass. On the far left is 1811 East Lake. How many of you are familiar with that? Have you heard of it? A couple folks. So I don't actually go there anymore. I used to have a couple patients there, but it's what might be referred to as wet housing. You guys heard of I imagine you guys heard of this term, housing first, right? That there used to be this impression that you had to earn your way to housing. You needed to somehow deserve housing. You needed to get clean and sober before you could get a place of your own. But it doesn't make a lot of sense, right? Like if you or a family member suddenly developed an alcohol or drug addiction, with a supportive family, with a roof over your head, maybe a job that's willing to support you, even then, beating addiction is incredibly tough. Now, try doing beating addiction without any of those support systems. Really, really hard. So a place like 1811 allows people to come and stay, even if they are not willing to cut back on their drinking, and but just offering services if those patrons want it. And it really dramatically reduces the use of the ER and sobering centers and detoxes and that sort of thing, and really helps people get back on track. The place in the middle I love going to. It's a place it's up in Shoreline. It's run by the Compass Center as well. It feels like a dorm. It kind of looks like one too. And it's a place where people really, I think, succeed. It's a transitional house where folks will spend months to a year or two as they sort of get back on their feet, doing job retraining perhaps, or finding out what education resources they have, or trying to get employed. And they've got staff on site who really help make sure that they're making appointments and that they're moving forward in their lives. And being away from some of the triggers can be a huge benefit as well. Being a caring and supportive environment makes it a tremendous difference for people. And then, has everybody here heard of the Seattle Stand Down? So we've got one over here in the corner. So the Seattle Stand Down is actually it's going into its third year. It's an annual event. It takes place at Seattle Central Community College every September 11th. And what it is sort of like a one-stop shop. It's a resource fair. You get all your community providers, you get dental services, you get medical services, you get provide backpacks and boots and sleeping bags and things that people really need to survive, and get them connected to resources. And there's a couple of other kind of stand-downs throughout the Puget area, and we try to attend those as best we can. So this is all really nice looking, right? Like it's the idea of going out, it's interesting, but does it actually have an impact? Are we reaching the veterans that matter, right? Well, of course all our veterans matter. What I mean to say is, are we reaching the veterans that we're looking for? Those really high needs veterans, those unconnected veterans. So I'll just show you a couple of numbers of what we've got. So at least in terms of the high needs veterans, we seem to be making progress. So this is sort of measured, like a proxy for medical complexity. Something called the diagnostic cost group score. Basically, having diabetes or cancer is going to give you a higher score than, let's say, foot fungus. And you add all that up and you see how sick someone is. And kind of our panel of patients is probably about 50% sicker than the usual Seattle patient. And the average patient here in the Seattle VA is probably another, I can't do the math in my head, but a little bit sicker than the average VA patient nationally. And then in terms of numbers, are we connecting folks? Over the course of this year, we've grown up to about 360 veterans who've gotten connected to the VA. And we're growing by about 10, 15 a month, which isn't as necessarily as quick as I want, but we're making good progress, I think. And then this is sort of the issue of collection, right? Like, we've got these people in the system, and does it actually make a difference? Is this sort of low barrier, easy access care impact medical outcomes? So one proxy for that is utilization rate. So if your disease is uncontrolled, you may show up in the ER again and again. So we've got some kind of preliminary data, which has been really encouraging. So when you look at the 6 months prior and 6 months post for first about 300 veterans that we got enrolled, we've got about 50% reduction in ER utilization and about 15% reduction in admission rates, which, and they're great numbers, but I think the thing that's been more exciting for me is watching this individual people get their medical conditions under control and get housed and feel stabilized again. This is basically something similar, essentially saying that the longer that we've had somebody on our panel, the less that they need to use ER. That they are really sort of getting housed, they're getting stabilized, things are turning around. So I'll take some questions at the end about the program after Mr. Blaze had a chance to talk, but I think sort of on a more personal note, one of the things that I think I've learned over this past year is that it's been an amazing experience. It's getting to meet all these wonderful men and women who've served, but I don't think we're moving fast enough. I think if we're going to meet that goal, if we're really going to end veteran homelessness, right? Because a lot of times we think of homelessness as a big social problem and structural problem, and it is. But we can sometimes come to think of it as a natural part of society. And I don't think that's the case. I think this is a tractable issue. This is something that can be taken care of. And I'm actually playing hooky right now from a summit that's going on down Beacon Hill with King County, Washington State, and VA, all coming together to try to figure out how we can move faster, how we can get more people into care. And a couple things sort of jumped out at me and that were really encouraging when I was there this morning. Back in June, a few heads of various community, a few of the community partners got together to sort of do a rapid assessment, or an assessment of sort of where we were at and how to get things moving. And they made a decision at that point. Like, we're just going to set a goal for ourselves. We're going to house 100 veterans in 100 days, which, especially for a lot of veterans who have been chronically homeless and are hard to reach, that's a really tough thing to do, actually. But they made some changes, and over the course of between June and September, instead of getting 100 veterans housed, they got 250. And you think about our goal of getting to 2,000 between now and the end of next year? I think it's possible. I mean, we're making progress now, and we just have to keep working hard. And it's sort of, as mentioned, sort of on a little bit more personal note, I think one of the things that I'm realizing is that there's a real limit to what I can do, right? Like, there's only so much you can do with a prescription pad. And I decided sort of to step out of my role as a clinician and start moving towards more policy change and that sort of thing, and decided to join up with advocacy groups. So Seattle King County Coalition for the on homelessness here in Seattle is something that's become really important part of what I see as my work. It's not just 9 to 5 at the VA, it's trying to end homelessness as a social problem as well. And something that's really encouraging to me is the fact that you guys have chosen to take this class, that you've got an interest in this issue. And I want to make sure, and I'm sure you guys already are thinking about how you can make changes now and, or what efforts you can make now, and then also your careers as you go down the line. But I just want to really encourage you to make sure that this doesn't fall by the wayside, that if this is an issue that's important to you, that you stick with it. For example, like at the VA, it used to be that there were no dental services available really for homeless veterans unless you fell into this very special category of. So dental services at the VA are limited to a particular subset of veterans, people who have really significant service-connected disability. But the dental department at the VA pushed hard, and they were able to create an opening, create funding for to provide dental services to at least a subset of our homeless veterans, those who are engaged in our programs for 60 days or so. So it's not perfect, you know. I would love to have every veteran who comes to me who says they need dental care, which is basically every veteran who comes to me, and get them into care. But even that was a huge step in the right direction. And you guys are going to be stepping into this role. So you're going to be in leadership. You're going to be providing dental services both in community clinics, your private practices, in institutional settings, and you can choose to provide benefits to those who really need it. So anyway, thank you very much. I'm going to hand it over to Mr. Joseph Blaze here, who's going to share his story with us. That's it. All right.
Thank you, Doctor. He's awesome. He's part of the reason why I'm here today, because I was homeless about 3-4 years ago. It would have been Tennessee 3-4, Nicholsville, and I thought that that's okay, you know, I'm just hanging here and stuff. But then what happened in my 3rd year is I ended up having some serious injuries or problems with my right foot, and it escalated more and more, and I ended up having surgery. And while I was at the Union Gospel Mission recuperating, that's where Dr. Reddy and the VASH team came in and spoke to me, and I said, be sure, I've never used any of my veterans benefits. I never had need to. I was a happy guy, I wasn't homeless, I had, you know, plenty of things in life going for me. After being homeless, though, things changed a lot. After I needed some physical help, I really was in need of somebody like the VASH program. So they ended up getting me some housing pretty quickly, I might add, and also setting me up with anything I need in terms of medical care and mental care. And it's been tremendous. I remember Reddy asked me one day that, what more can we do to reach out to you guys? And that was a really hard question to answer, because I was a vet living amongst a lot of homeless people. And there are quite a few of us vets out there, but a lot of us came through the 60s and 70s, and the Vietnam War wasn't all that great of an experience. And so we lived with this for many years. And then if you become homeless for a few years, you get to think so little of yourself, and you don't get treated like you thought you should be. And that even means at the VA hospital sometimes. So a lot of us didn't want to even use the services. We felt it was useless. So I just didn't get my unemployment check and tend to get drunk every day. So what happened is, because of the positive support from the VASH program, I really started seeing things a lot differently. There was hope, and that there were people in the community that wanted to help veterans out. Coming from a person who went through the Vietnam era, you can't imagine what that means to us guys. You're not going to find any homeless World War I veterans or World War II veterans. Most of the homeless vets you're going to find are Vietnam veterans who are in the middle-aged stage of life. They do have many medical difficulties. What's even more is mental difficulties. They don't trust, they're not caring about themselves, let alone anybody else. That's where this program, once again, is so important. It helps you transition through. I remember when I finally, through John Jackson, who's a social worker program, got me into some housing. Everyone's there going, all right, you got a maid, you got an apartment now, and all that's great, you're not being homeless, all right. It was hard to transition. It really was. I felt more comfortable being around a bunch of homeless guys sitting on drinking in a tent situation than to actually have a clean apartment. And, you know, it was like really a strange transition. What I needed was stability, and that's what the BASH program does. I need consistency. I need to know that, yeah, like he mentioned, a lot of the veterans or who call up, they can't get to the VA, emergency rooms, things like that. They provide me with, okay, on Fridays, I see a social worker at this time. It gives me something to look forward to keep my mind active, or else I'm sitting home, not homeless, I have an apartment, but I still feel homeless inside. I don't have a home that integrates with myself. This is changing quite a bit. So they've got a really big, hard caseload to deal with, because unfortunately, a lot of veterans I've met on the street, the true homeless ones, they don't trust the VA, they don't trust it. A lot of it's because they've been so far out of the loop, whether their choice of drugs or alcohol, or just mental instability, they don't know how to reach out. And so they never did. I never used VA services for 4 years, because I didn't need it. Boy, when I needed it, I was really glad that the BASH program was there to help me out. And so I made it to the Operation Stand Down with the BASH team. That was quite an experience. So, you know, when Dr. Reddy asked a little while ago about, is this doable to end homelessness, I was one who did not raise my hand. That's such a big project. And now that I know more about it, because I've been involved with it for almost a year now, it's so tough, it's so intricate, and you have so much red tape. You know, it's still the government. You go to the VA, it makes it almost twice as hard sometimes. But I end up having faith in every day when I go there. And there's a day that if I feel like going in just to talk to a social worker or a therapist, whatever, it's like instant walk-in service. You don't even have to wait a while till they get you. But it's not like, you know, surgeries, yeah, they have to sort of like, you know, set you up with time for it. But if you have that day that you're really feeling bad, you can walk in there and they will have a therapist talk to you. Or if I'm having some discomfort physically, I can go in and know Dr. Reddy or his nurse Brian will get to me as soon as they possibly can, and they show a real interest. That was really hard it really hit me really hard, that the compassion they have for not just us homeless, because I was a veteran as homeless. Met a lot of veterans in my life out there in the world, but not all that many I've met are homeless. They're either too strained by their own life, or they're too ashamed of what they're going through, or they just are so pissed off at life they don't care. They don't trust the government, they don't trust hospitals, they don't trust the VA, so it's really hard for them to connect with a lot of these guys. In a way, that's where my calling is coming to play. Since I went through this, I sort of felt that with all the stuff that happened to this point, I was just another one of the people who are just there. But I started to see so much progress with this program. I love this right now, telling people about the importance of helping out not just veterans on this Veterans Day coming up, but the homeless veterans. They are truly strange cats. They really are. They don't trust a lot of people. And a lot of them have dealt with mental instability for so many decades without help. It just gets harder as you get older. You get more set in your ways. And physically, you just let yourself go. You don't care. What the heck? But this is, once again, a great program, and I'm really pleased and glad to speak about it today. And also, like with Operation Stand Down, I feel I'm not a case, as my doctor put me earlier. I'm an experiment, not a case. But, yeah, I'd love to. I mean, anybody I see in the street, anybody I meet, as in the Union Gospel Mission, I met quite a few vets there. They had no idea that this program was available. So the onus is on them to reach out to us. And I feel the onus on me is because I've felt so much support in my growth that I am wanting to and willing to. I have this passion now to go and tell people, whoever it is, whatever field, that can help homeless veterans out, that, yeah, I would love to do it. So I'd also like to thank you guys for having the interest of coming here today. And if there are any veterans you in the audience, like Mr. Clark, then if you are a veteran, thank you for your service. If not, Veterans Day is coming up. Say a prayer, say hello. Know that a lot of us have, especially through the Vietnam era, didn't come back feeling all that support. When World War II veterans came back for tick parades, everyone loved all the veterans coming home. And the ones coming home now, because they're coming back to a younger generation, about the same age, yeah, they, I think, get a lot of support too. They're in the same level of ages. But the World War II veteran and the Vietnam veterans, it's a whole different world for us. Most of the people our age are either died or they're, in a whole different sphere of life. So that's why the homeless veteran program for people around my age is imperative, because if it goes any further, I wouldn't be here today. And I wasn't ready for it to happen. It all had to take timing, and that's why I'm so glad I have people like Dr. Reddy and Mr. Jackson, who have the compassion to help veterans out, homeless veterans out. So I guess that's my little spiel. I want to thank you again for coming. Any questions you guys got for me, maybe? Yes, no, yes, no, yes, no. Okay, good.
Hi,
Yes.
I had a question for both you and Dr. Reddy.
Sure.
A couple of questions, actually. One around, you mentioned that the VA is expanding dental services to ones who don't qualify for standard VA dental, but that's only limited. What other resources do you have for the patients that don't qualify for the program?
Not a lot, honestly.
Okay.
So I think the qualifications right now are, so I mentioned a variety of different housing type services, right?
Mm-hmm.
One of those housing services is this grant per diem or pay by the day kind of program. And for veterans who are in those programs for 60 days, they get these dental services. But a lot of times I have folks come in and they don't fit into that category. And right now, I mean, honestly, I don't know where to send them. Like, King County Public Health has dental care. I know the UGM on occasion, you guys go out there. Yeah, especially for emergent stuff, like I've got a guy who's got, an infected tooth or something, like it's antibiotics until I can find someplace for him.
Yeah.
There's a mobile dental van as well through through King County, but getting there is tough too.
Yeah, well, and especially once you've got all the teeth out, what do you do then?
Yeah, that's really hard.
The second question. And then also, one thing I'm curious about for us who might be working with homeless veterans at some point, if you had any advice on how to work with patients that might have PTSD and to avoid triggering and to sort of support in a way that wouldn't trigger PTSD.
Well, may I talk about it for a minute?
Oh,
You
yeah,
got it.
go, because I don't suffer.
Yeah,
Thank
great.
you.
But you've run across folks, but there's this. Thanks. So there's this idea called trauma-informed care. I don't know if anybody's heard of that term, but it's this idea that by the time somebody shows up on your doorstep, they've already been through a tremendous amount. And trauma, sort of in the traditional sense, maybe they've been in combat, or they are suffering from abuse in childhood, or whatever it might be. But additionally, there's sort of trauma of living on the streets, or not knowing where your next meal is going to come from, and the tremendous stress that can be under. And so when somebody shows up, and I think the biggest, so I think there's this term, right? So when somebody comes in and maybe they're irritable, or they seem very angry for reasons that don't really seem clear to you, there may be this inclination to think in your head, what's wrong with you? But instead, the question should be, what's happened to you? And you don't necessarily need to ask about it, right? If you want to get into that, that's fine. But to really give them space, just sort of don't push things too hard. Ask them if there's anything you can do to make them more comfortable, and if there's anything that is bothersome to them or that makes them more upset. Has anybody had an experience like that where they've run into a clinical situation? Can you tell us about it, if you don't mind?
Well, so the one instance that I think is most significant for me and why I was curious, because I didn't know what to do, and still would be kind of unsure. So I've actually worked with a veterans dental van in Skagit County to supplement the VA's dental coverage. And we were having a stand down, and we had 2 dentists on board, and there were 40 veterans, all of them needed dental, and we could see maybe 18 if we really rushed the dentists. And so we had one patient who reacted negatively to the changing schedule, and to we'd say, okay, we'll get you in an hour, we'll get you in an hour and a half. You're next in line, and he would see someone else go in the van, and just kind of had an adverse reaction to that. And since then, I've kind of learned to be maybe a little bit more flexible and let them know I can't give them a direct time, because I know that they're not going to maybe get that time that I'm saying, but to be clear and communicate it and support it. But I wasn't sure if there was a good way. I like what you suggested.
Actually, I think that's a great point, which you were talking about, that I've made the same mistake, or not mistake, I've run into the same issue that, things change, and clinic gets busier, or something comes up, and there's something emergent, and so you take somebody ahead of somebody else. But when you're sitting that man's shoes, or that woman's shoes, and for them, they may have been passed over already time and time again, that they may have they feel slighted, they feel disrespected, because even if there was no intent, that's how they feel, and you sort of can't just change that. But I think exactly what you said, to be as open as you can, to tell them up front what you are capable of doing, and don't make promises. And I think that's something I've had to learn the hard way, that I don't want to promise something that I can't deliver. It's always about, what you can promise, and I think you should promise, is I'll try my hardest. I will do the very best I can for you. But to say, I'm going to put a roof over your head, or I'm going to make sure you get dentures, I'm going to try. We're going to do what we can. Can help prevent some of that. And then at the end of the day, though, people will storm off, but don't think of that necessarily as a failure. As long as you were kind and compassionate and professional, that person will come back, or will hopefully come back. And I've seen that happen, where people were incredibly angry in ways that I just seemed off the charts, and then would eventually show back up. And I didn't mention it, I didn't get into it. It's like, thank you for coming back. Thank them for coming. You're welcome. Any other questions?
Oh, no, I was going to, another comment on that. The best intentions with the medical community is they really want to help us vets out, and they promise them everything. Oh, we'll do this for you, do this for you. Their minds aren't activated that way. So what happens is, they don't think you're lying to them, they just think you're not caring. One of the things I love about working with Dr. Reddy and Nurse Brian is, there's been some days I've gone there and walked in clinic days, he's just so busy, he can't see me, but that's okay, I know him go in the next day. But his Nurse Brian was awesome. He'll come out a lot of times and say, by the way, we're running a little late today, it might be another half hour. Then I'm just here again. I know I have been overlooked. But same thing, if I saw people not going into his office, I'd say, hey, how come these, kind of thing. So, yeah, you're going to be really honest enough forward with them, but don't make any promises of times. That can be very tricky, because you don't know if the person you're working on is going to take an extra half hour. And this person's sitting there, especially if they're homeless, they're really agitated. Now they're going to have to deal with, the tube still hurts, and they're going to take a bus. If I get changed, take a bus back. So, yeah, do everything you can do is Dr. Reddy recommended. But, don't promise them everything. But if you can show it compassion in your eyes and your voice, it's honest. And they can accept that. They'll even wait an extra half hour. Or they'll say, can I come back tomorrow? Yeah, you come back tomorrow, maybe first in the morning. That gives them a feeling that they're not just getting forgotten about. And once again, a lot of people have that attitude towards hospitals. That one's carrying the chip on their shoulder, sorry to say, especially the VA hospital. We figure we should do everything for us. Heck, we fought for our country for this. It doesn't work that way. It's all bureaucratic. But the intention is the compassion that Reddy has shown. That yeah, be honest with them and let them know before that enterprise that by the way, we're in. I hope you don't mind. You bring a book along and a magazine for it, and get your cup of coffee. Not that far, but still, if you do it before the event happens, especially if they are suffering from those kind of syndromes, yeah, it's going to make them feel a lot more relaxed. But when they get in there, they're going to have an attitude. Well, no, you're a half hour late. No. You know, it complicates things in their minds. Great question, though. Thank you, guys.
Actually, just wanted to second the thing about sort of acknowledgement. I think that's incredibly important. I mean, think that in your own lives, you know, if you walk in a store or you're at the doctor's office, if you walk in there and nobody meets your gaze, nobody makes eye contact with you, nobody acknowledges you, and you just are waiting there, you feel terrible, you feel disrespected. Even if it's not intentional, you want somebody to at least know that you're there, that they are trying to take care of you.
I've tried to think about it as like bringing the best sort of customer service
Yeah.
that you would expect in, you know, the best medical office
Absolutely.
to, you know, wherever you're working, whether it's at a stand down or a suite. So,
And I love the idea about bringing tea and coffee. Like it's something where actually, when we get funding, and I have a little more control over my own space, we'll be able to do that, I think.
I'll be certain.